I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Falsel Syed. Welcome to another episode of Fridays with Faisel. We're here because everyone deserves access to quality medical care, and ChenMed needs physicians to take care of them. Today's topic is the 4 waves of COVID. I keep reading every day, more and more actually, about just looking at the survival rates when you're looking at COVID, when we're dealing with COVID. And preventing COVID is much, much more than preventing death. So let's get started. Robert.
Hey, Faisel. How's it going?
Good to see you. Dr. Dan. Dr. Dan's going to be moderating. Hey, welcome back.
Yeah, thank you, Faisel. Looking forward to an interesting discussion today. Since we're hitting new peaks in COVID, I think downplaying what's happening is we do it at our own peril at this point.
Exactly. I mean, even last week when we crossed the 60,000 cases per day, I was expecting for widespread just locking down of just different places of parts of society, and now we're double that. We're almost double that in the last week.
Yeah, I think we hit 100,000 this week.
Yeah, I think yesterday was 120,000. Yeah, so yeah, it's we're on the vertical part of the curve now. We need to figure out how to bend that curve over again.
That's right. So I'm looking forward to a great discussion today with the 4 waves of COVID. Robert, let's introduce our guests. We have 2 repeat guests.
So the topic today is the 4 waves of COVID. So we were just talking about how we reached 120,000 infections, and we obviously want to talk about that element, but there's other pieces involved here at play with COVID. And so the 4 waves. Let's bring up that graphic there, if possible. We have a graphic. Yeah, so, and this one actually has 5 waves, but the concern is sort of the long-term consequences of this. So the initial sort of waves of the infection itself is one topic of discussion, the deaths and sort of the quality of life impacts from the disease itself. Then we have a certain degree of issues from delayed care for existing chronic conditions. So there's some level of concern about that coming and catching up with us down the road. And then there's also a level of concern about sort of the mental health consequences and social determinants of health consequences of this, from widespread unemployment that can lead to bad health outcomes, from just general pandemic infection stress, from stresses related to the election. I think we've all been perhaps experiencing a little bit of that this week. In addition to the fact that winter is coming, viruses spread better in cold air, and it doesn't look like things are slowing down at all. So I think we're here to talk about a number of different ramifications for the healthcare system, for individuals, and for physicians in particular as well. So today we have 2 wonderful guests. We have Dr. Fernandez from ChenMed, and we have Dr. Bricker from we just know him as from Dr. Bricker, Dr. Eric Bricker. He is a true mainstay on LinkedIn, and we're glad to have him joining us once again. He was with us a couple weeks ago, and I think we have a good group to talk about sort of a number of different ramifications from COVID. So we're looking to kind of look at this holistically, and I'm excited to get started, Faisel. So where do you want to start?
Robert, I wanted to talk with you about a post I saw this morning. I think, Eric, I texted you about this post where there's a cartoon of different lines of people coming to the gates of heaven. And so you have heart disease with a pile of people going into the heart disease who died of heart disease. line of people. Then they have the pneumonias. They got all these different things. And then COVID, there's just a trickle number of people. And it was a doctor who posted saying that what a brilliant image and what a brilliant post showing that how few the number of people are who are actually dying from COVID. And I thought to myself, oh my God, if we've gotten to the point now where doctors are starting to join in on this rhetoric, I think it's important for people to just understand when we're talking about life expectancy in general. If we got rid of all of heart disease in America, almost half of the country suffer with cardiovascular disease. If we got rid of all of heart disease, we'd prolong life expectancy by 7 years, right? And when we look at cities like New York, the life expectancy gap between Manhattan and Spanish Harlem is 10 years. In Chicago, between one part of Chicago and the other part of Chicago, 16 years. In New Orleans and NOLA, we have centers there in NOLA. We're in the zip code where there's a 25-year gap. That means that the life expectancy in that zip code is in the late 50s. And it's because of the social determinants. It's because of basic things like access to food, access to safe housing, transportation. And my concern with COVID, that from the survivors especially of COVID, now we have almost 10 million people who survived COVID. We're having so many new cases. We're having more survivors. What will happen to them once their income starts? So let's say if they lose their jobs because of having the long-term effects of COVID, if they start falling through the cracks. Already before COVID, the country was doing terribly. So far as access to healthcare was concerned, we had 30 million Americans who didn't have health insurance. We had another 40 to 60 million Americans who couldn't afford their copays or deductibles. They're effectively underinsured. So my concern now we've got this on top of it all, and people are downplaying the impacts to society just by looking at the mortality numbers.
Yeah, so it goes beyond just the impact of the mortality and the initial sickness of the disease. There's some people that are experiencing longer term consequences that we have yet to know very much about. It takes time. Science takes time. So some of those are going to continue to roll out over the next couple of months. We are still surprisingly, I was on a phone call this morning and people were like, well, if things get back to the way it was, with the risk in March and April, and I'm like, whoa. I'm like, we're actually well beyond where we were in March and April. There's just a difference in attitude towards it, a difference in response towards it. So the actual disease spread is actually much, much worse beyond what it was in March and April. So I like to set that as a baseline. But Falsel, what I'm hearing from you is that it's more than just worrying about being sick here. There's a future consequences from this condition. And I'd love to kind of throw this off to Dr. Fernandez. Like, what are you seeing in some of your clinics, and how are some of these longer term effects showing up right now for you?
Yeah. Hi, Robert. So definitely, looking at your 5 graphs and taking everything into context, COVID is here, COVID is real, and we're going to get through COVID together if we keep being safe and following precautions such as washing your hands, social distancing, and wearing masks. What I'm seeing in the clinic is a predominant fear, and that is a very serious feeling. Fear is not per se a medical condition. It's not something we can quickly treat, but we can counsel our patients on managing that fear. We need that fear to be converted into the power of prevention. Stay safe from COVID. The power of prevention. Stay connected with your primary care doctor, which here at ChenMed will just a text message or a call away, and do not let your chronic conditions go unchecked. Because although COVID is extremely serious and is extremely prevalent, some of the patients we have might be at much higher risk of having complications from the chronic illnesses if they go unattended than even COVID itself. So COVID, I don't see COVID as a bubble. COVID is here. COVID is within us. COVID is with you, with the heart disease, with your families, and all the 5 layers that you described in the graph below, I see in every patient. I see patients who have had good outcomes because despite COVID being here, they've kept in good contact with us, with their primary care doctors, and we've been able to keep everything at bay. But those patients of mine that have been affected more seriously by these conditions, perhaps a loved one got sick and have not had access to get to their doctor. Some of my patients are traveled outside of the country and it's not been as easy to come back. I have seen the ramifications. I can give more concrete examples as I go, but I can tell you that behind each of those curves and each of those graphs are lives that I'm privileged to listen to, are lives that I walk together with. I don't want us to give up. I don't want us to lose hope. There's light at the end of this tunnel, but it's not one bubble and another. We're in this together, and we have to keep staying in this journey together.
Awesome. Thank you, Dr. Fernandez. So, Dr. Brecker, in light of sort of the holistic view of COVID moving forward, what trends are you seeing, and how are you thinking about adapting to the potential ramifications from this?
Yeah, Robert, thank you so much for asking me that. And I think Dr. Fernandez really hit the nail on the head, and that is that there are direct medical consequences of fear or anxiety or worry or whatever you want to call it. I mean, there is a biological chemical response to fear. And a lot of people cope with that fear in ways, like Dr. Fernandez said, that are detrimental to their other underlying chronic diseases. Now, what do I mean by chronic diseases? Like most of the time, we're talking about hypertension, diabetes, congestive heart failure, especially for the Medicare folks that ChenMed take care of, and then also emphysema. And so I guarantee you that many of you have patients in your clinics that have all four, right? It's actually fairly common to have all four.
That's right.
And what do people do, understandably so, when they have fear, is they have a variety of coping mechanisms that might not be healthy for them. So in other words, they have emphysema and they still smoke, and they're smoking more. Or they're eating, the medical term that we use is dietary indiscretion, but they're eating foods with more sugar and more salt. Those are really, in the acute sense, those are the two worst, more so than the fat, right? But the sugar is going to knock your diabetes out of whack, and the salt is going to knock your hypertension and your CHF, your congestive heart failure, out of whack. And I will tell you specifically that my great-grandmother-in-law, who, bless her heart, is 94 and living at home by herself alone and normally does quite well. She was hospitalized for probably the first time in like 6 years for congestive heart failure. And it was really because of dietary indiscretion. And like a lot of people, like Dr. Fernandez says, she was having fear and anxiety. And one of her coping mechanisms, again, like a lot of people, is to deal with that by maybe eating more of stuff that she shouldn't have been eating. Now, the very specific biochemistry behind it is, I'm sure many of you are familiar with this, there's a pediatric neuroendocrinologist out of UCSF named Robert Lustig, who wrote a book called The Hacking of the American Mind, that talks about how people will go to dopamine-generating substances, and it can even be like drugs and alcohol, but also sugar and also cigarettes. And that really the way, this is not all doom and gloom. Like Dr. Fernandez says, we're all in this together, and there are things that you can do. And the way to not be reliant on dopamine-inducing chemicals that are oftentimes harmful to our bodies, like the salt and the sugar and the smoking, is to rely more on what is known as serotonin. And one of the best ways to boost serotonin in our brains is through positive interactions with others. And so talking on the phone is awesome, or Zoom, or whatever you want to do, but you have to remain connected with people. And I will say, specifically for my grandmother-in-law, that my wife has spent more time talking to her on the phone. And I think it's been helpful. So many of these things are not in the form of a pill, not in the form of something that we quote unquote learned in medical school, but they absolutely have positive biochemical effects on the brain that can be very constructive.
Yeah, Eric, thank you for saying that. I know Falsel and I have been talking to each other on the phone a little bit more. There's been very positive conversations we've been having.
Well, Robert, let's be truthful. Can we be truthful? we're talking with each other more on the phone because of my kids. My kids are
Yes.
always asking about Robert is the celebrity in my house. If there's any chance to talk to Robert, we were in the U-Haul yesterday, and I saw a text from Robert, and my 3-year-old was like, Robert, and he wanted to talk to Robert, so I called him on FaceTime from the U-Haul. They love you. They love you. So
and he was very shy about that. But those types of positive interactions, I mean,
Yes.
Eric, thank you for getting into such detail there. I think that really kind of underscores a lot of what we see going on right now. And I know for me, what's very concerning is sort of the longer term mental health consequences of this fear and anxiety. So, people aren't having those social interactions that are positive. We know loneliness and isolation is a pretty big risk factor for depression. And so we also know that depression is inextricably linked from how people care for themselves and how they manage their chronic conditions. And so the fear, we saw this on the United Healthcare or United Health Group earnings call, I think back in September, where they had exceptional profits because people were delaying their needed care, so they didn't pay as much out in MLR, so they had pretty good profit margins. And what they said and expressed on the call is that they're expecting a lot of ramifications from this delayed care or from the consequences of COVID in the next year or two. And so those are sort of those waves that the health system is also sort of preparing for, because they're still dealing with resource constraints right now, but the fear is sort of in the future for patients that are going to be sort of developing some unhealthy behaviors due to the depression and anxiety. So I think that underlying physiological mechanism is a great way to explain that. And so one thing that I think is interesting is, like, Falsel, you and Dr. Fernandez, you're dealing with sort of a dual eligible, probably majority retiree population on Medicare. Dr. Bricker, I want to throw this back to you real quick. The mental health ramifications of unemployment, given that you spend more time in the employer space, is a big risk factor for a lot of this depression. And so that's something that I'm particularly kind of worried about with sort of COVID-19 and some of the issues with sort of the economy that is then going to impact health. Do you have any thoughts on that?
Yeah, so I did my medical school training in Chicago at the University of Illinois. So our campus is really like across the street from Cook County Hospital, which is one of the most famous hospitals, kind of like Jackson Memorial in Miami. It's very famous, where the TV show ER was based off of. Mm-hmm. And one of the things that all of the professors in my medical school taught me was that being poor is incredibly stressful. Okay, being poor is not just about not having money. I know, as silly as that sounds, it is incredibly stressful to be poor. And one of my mentors, Truman Anderson, said, "Look, money doesn't make people happy, but not having money can certainly make people miserable." Mm-hmm. And so if there are things like, whether it's losing a job or losing health insurance, what have you, that are decreasing your income, and that's just going to then increase the stresses of being poor. And I think that one of the great things to increase serotonin that a lot of people do in Florida and in Texas and other parts of the country is they go outside, which frankly in Chicago you really can't do for like 4 to 5 months out of the year, because it's just too cold. I remember at the outpatient clinic at Cook County Hospital was called the Fantasy Clinic. They would call it the Fantasy Clinic. And I would tell my patients, you need to get outside and exercise more. And they would just look at me and be like, Dr. Bricker, it's February in Chicago. And I'd be like, well, can't you like walk at the mall? And they'll be like, you don't understand. I live on the near west side of Chicago. There is no mall for me to walk in around here. So, and that's just where, I mean, I'm laughing about it, not because they were silly. It was because I was so stupid for thinking that I could have some sort of, answer to their challenge of poverty. So it's beyond the discussion of this call today to discuss ways that we could address those things. But it is a real, the economic consequences are absolutely real.
Yeah, absolutely. And, what I think is really relevant for Falsel, you and Dr. Fernandez population is that they are older adults. We know that they suffer from loneliness at a higher rate, especially if they're living by themselves in their home. And they're also at higher risk for severe complications or death from COVID. So they are probably under a unique level of stress during this time. They are already potentially sick. And so, I mean, your clinics are serving a very important need right now. And, I I'd be curious to hear, if you are doing anything specific to address those problems with your specific patient population, with the older adults who are the sickest and potentially the poorest in the country.
Yeah, we literally, every single one of our centers are located in the same neighborhoods as federally qualified health centers.
Mm-hmm.
Now, these are the most underserved communities. They're all on fixed incomes. But at least in Tampa and Lakeland area, I mean, you're talking $600 to $900 a month in Social Security. And Eric, you're right. When you said that they may have all of these chronic medical conditions at one time, actually the average number is somewhere between 5 and 7 chronic medical conditions, depending on the part of the country we're in. So we're dealing with a very medically complex patient population who are all on fixed incomes, and they're underserved, and many of them have felt forgotten. So, we're expanding as well. So we're expanding, we're going into these areas. And when we come in there, many of them have never had that type of relationship with a doctor before. With things like diabetes. Now, the number, I was shocked to read the number that now there are over 100 million Americans who either have pre-diabetes or diabetes. And I can't tell you how many times we've established a patient who's been on insulin. Now here's our average patient is 72, 74 years old. Eric, you will not believe this. How many patients we've had who were put on insulin 2 or 3 decades ago in the emergency room setting because, they got diagnosed, they had hyperglycemia, and then someone refilled it. They see a series of people who just refill the insulin, and then they'll come see us, and then we'll get the history and the story, and we'll say, wait, you were started on insulin in the emergency room and it was just continued over the last 20 years? And they'll say, yeah. Nobody ever talked with you about lifestyle. And they sort of do like what you did with telling them to, we have our way, no sugars, no sweets, no soda. And, we'd go into exercise, go for a walk outside in February, go to the mall, that sort of recommendation. That's what we all do in medicine, right? We're just so disconnected from the realities of what the patients see on a day-to-day basis. Mm-hmm. And so then we have those conversations with lifestyle interventions, letting them know things that basically, when you're dealing with this population, if you're making a food recommendation, you better make sure it's available in places like Walmart. So if Walmart will have cauliflower rice or mashed cauliflower, if we're trying to reduce their carb intake, and they do have that. It's like less than $1 for a packet of that.
Right.
To give some suggestions to these patients, and believe it or not, within months we get them off of insulin, just with lifestyle, and then getting them on oral meds. I know Dr. Aymara Fernandez, sorry, actually, can add more.
Yes, absolutely, Dr. Faisel. Here we have some tools, Robert, because you did ask for some concrete examples. We actually have something called the ChenMed diet, which was created by our doctors for our patients to not just tell them what to eat, but also show them. And it has recipes and it has alternatives for budget-friendly, mainly vegetarian-based. So we do use that. We also, especially over the last few months, we've identified the importance of addressing the social determinants of health on a one-to-one basis. And all of our patients are getting calls from our social workers to identify needs such as food, make sure those who had food insecurities have access to food. Even though our patients are older, most of my patients actually still work, or some of them are looking for work, and our social worker also helps them with that, as well as with housing. And one aspect of this pandemic that I would like to pause and comment on, because I witness it every day, is children. I do take care of the elderly, but the effect of this pandemic on children has actually been palpable on my patients as well. My patients have become teachers, have become caregivers. They're now those loved ones who sit for 3 to 8 hours in Zoom classes with their loving grandkids, or they're the grandparents who receive those who are going to school from school with, again, lots of fear. So although we do take care of the elderly, we're privileged to really see the social aspects of our patients' life because of the frequency we see them. And the challenges, I'm sure we could spend hours and hours talking about the challenges, but I did want to introduce that aspect of children because I think that's become a new stress that's more prevalent amongst our patients. And I love kids, and I want to thank all the grandparents out there who, in the middle of this pandemic, has stepped up and become these amazing teachers. Thank you.
Excellent. Thank you, Dr. Fernandez. And I love having you on the show because you bring just such a wonderful perspective that, you know, lets us see into the sort of the lives of your patients. And so I always appreciate getting your perspectives on that. And I do think, can we bring up the other graphic? And I think this is a good time to talk about this. Let's see here. Yeah, so this is, I think, a really good example of what we've been talking about, and this really summarizes it nicely. You can see that first wave was the immediate, mortality and disease of COVID-19. You can see the impact of resource restriction as the second wave. So we're seeing that right now. I just actually wrote a paper that was published in the NEJM Catalyst 2 weeks ago on ICU nurse demand during COVID. And as COVID spikes occur in each state and now across the country, we're seeing ICU nurses in such high demand, and there's a limited finite amount of resources. So unlike ventilators that you can really pump up and you can manufacture more of, it takes 6 years to make an ICU nurse. And so those resource restrictions are severe, and there's been reports coming out of hospital facilities that are really struggling to get access to that workforce. And that's what we do at my company, Wanderly. So we are a staffing marketplace for clinicians, primarily RNs, and we've seen tremendous amount of demand for ICU nurses. And when you have so many patients flooding the system and you start to get overwhelmed, then you start running out of those ICU nurses. We particularly work with travel nurses, and so they're able to take 3-month jobs and go between different states to meet that demand. But when demand is everywhere, those resource constraints are going to start to show impact for health outcomes for the whole country, and particularly where those spikes occur. And then what we can see here is that sort of third wave is that interrupted impact of care on existing chronic conditions and new ones that may be exacerbated because of the inability to see typical primary care physicians during this time because it might be unsafe, or just the general stresses that we've been talking about. And then as we can see, that fourth wave, that's psychic trauma, mental illness, economic injury, and burnout for our healthcare professionals in particular, I think is really important. And I think going off of what Dr. Fernandez just said, the children whose lives have been uprooted by this. It's not just the adults who are really paying close attention and who are afraid of potential economic impact, but children who can't go to school and see their friends, who aren't getting as much social stimulation, who are really having a difficult time with distance learning. That is a really important group that may have some impact going down the road from COVID-19 as an additional wave as a part of this sort of fourth area that I think is really important. And then I want to key in on something here really quick, which is burnout. All three of you are physicians, and so is Dr. Dan. So physician burnout, nurse burnout has been a huge issue for years, and this has really exacerbated that quite a bit. So I'd love to hear from each of you on sort of your take on physician burnout, as well as what COVID-19 has really done for that. I know ChenMed, you guys are really worked to solve that problem really well. And I'll share a quick story before we turn it over to you guys. Is my cousin, she's an ICU nurse supervisor at Christiana Hospital in Delaware. And I talked to her the other day. I texted her after our paper came out, and I said, I was like, how's it going? We wrote this paper, thank you for all the work that you guys are doing. And she said, we're having a hard time. She said her nurses are really struggling with this. And, the burnout and the risk to that clinical staff workforce is really real. And as this, continues out, how much longer are they going to be able to work at the level and the capacity at which they're working right now? So that's something I think we all need to think about and bring back to the forefront. It was really big in March and April, and we really lost that sort of support for those frontline clinicians. So I'd love to hear your take on sort of clinician burnout during this time, guys, and how you've personally potentially been impacted by it.
Hey, Robert, there was one question here, and I think it could spread into this. I mean, speaking of burnout, part of it is feeling like you're sort of fighting a losing battle at times. And so, and I'm sorry, I'm not even going to attempt to pronounce her name because I'm going to butcher it if I do. And I don't want to insult her by butchering her name. But this is a great question. How can we spread logical fear? And part of it is how can we spread fear that encourages people to do the things that they actually do have some control over versus things that they don't have control over. So if you all could work that into your discussion here, I think that would be great.
Yeah, I think with the question there, kind of translating it, it might be that it's, how can we encourage people to do the things they need to do to prevent, getting sick and to do positive behaviors for themselves rather than, having, just fear that paralyzes or fear that, doesn't promote, positive preventive behaviors. So I'd love to hear from you guys on that one. I think we've talked about on the show before that fear is not the greatest motivator. You have to kind of use positive tools to motivate people. And so simply telling people that you're going to die doesn't work.
Fear only works until the people get over it. Whoever's receiving it, once they realize that is something that they can overcome, then they'll just go right back to whatever the behaviors were that they were doing. It's not long lasting. Fear works in the short term. It's definitely not long lasting. We know that with motivational interviewing. We're the first week of October. At the first week of October, we had already crossed with flu vaccination rates as a company. We had crossed well over 40%, pushing past. We're probably past already now, way past 50, 60%. I wouldn't be surprised now. But that's at the first week of October. At the end of the flu season in America, less than half of all American adults are vaccinated against the flu. And we're somewhere like across the board between 70 and 80% as of last year. This year, I'm hopeful that we're going to cross the 80% mark. And we have several of our doctors who have over 90% of their patients vaccinated against the flu. And the reason why, and such a challenging, and imagine, and that's with such a challenging patient population, it's because of that relationship that the doctors have with the patients. It's how you engage someone who doesn't want to do whatever it is. Like, you're a yes, the person is a no. And we have a culture that does not prioritize prevention. Someone told me just this last week, well, if there wasn't an election, we would have responded much better to social distancing and wearing a mask. And I said, I don't think so. Because I've been reading have you looked up some of the newspaper articles from the 80s with seatbelts? Oh my gosh. I mean, there were petitions signed. Even from Boston, there was a petition signed with over 140,000 signatures. And this is Boston, Massachusetts, saying that it was unconstitutional for the government to get involved and for a police officer to be able to pull someone over because of not wearing a seatbelt. So I think just as a society, I think we just struggle. We want to be able to take a Tylenol for a headache and not look into what the cause of the headache was to begin with to prevent future headaches.
Yeah, Eric, I can see your seatbelt right there. I think that you're sitting in your car there, so what a perfect example. But I think we do not prioritize prevention, and I do think that the impact on clinicians as well, may affect the ability to actually effectively communicate to patients. So I'll bring it back to the burnout question here. How have you guys seen this? How have you personally been affected? And, what do you think the impact is on your patients?
Well, physician burnout. Yeah, I can get it started for Eric. I've heard people, when I hear anyone saying that, well, doctors are getting burnt out because of medical complexity, they just don't know what physician burnout is. Doctors are not getting burnt out from medical complexity. We enjoy that. We enjoy medical complexity. Doctors are getting burnt out from all the medical complexity of their documentation of each patient encounter in fee-for-service, and with the hybrid value-based care models, all the documentation they got to do in between visits. That's what's burning out. That's what's burning out doctors. It's not medical complexity.
Mm-hmm. Gotcha. Yeah, Eric, what do you think?
Oh, he's muted.
Oh, he is.
Here we go. Unmuted. Sorry about that. So I keep in close contact with my medical school and residency friends who work in a variety of different settings, whether it be in the hospital, in the outpatient setting, academic, in the community. And Dr. Falsel is absolutely right. So really what causes the quote unquote burnout is everyone has different euphemisms for it. I'll just use the euphemism of frustration. And you call it anger. I mean, you call it all sorts of things, right? It's that chronic sensation in your stomach when you're trying to get something done for a patient and you can't for a variety of reasons, either because it's the electronic medical record or it's administrative rules of the hospital or it's the insurance company. Sometimes it's the patient's behavior themselves. It's very easy to become resentful of your patient's behavior themselves. It's just a reality of how things work. And so I think the way that the physicians have been, that I'm in contact with, the way that they've been dealing with that burnout is by it is really necessitating just not seeing patients and not practicing. It's just you have to have time away from it. There's no substitute. You can say, fine, the system's broken. I mean, to a certain extent, we're paying the piper. And for us to think that we're going to change the quote unquote sources of frustration that exist within the system today are going to change now. Like, it's not. I'm not trying to be pessimistic, but it's not going to change tomorrow. It's not going to change next week. It's probably not going to change next year. And so the only way to cope with that is you have to have a break. You got to have R&R. And all of my colleagues that I talk to say that they feel like new people when they get that time away from the clinical setting. And then they go back and they get their battery totally drained. And then they have to recharge it. So it's really a matter of them working with their colleagues, their administrators, et cetera, to make sure that there absolutely is time for the battery to be recharged. I wish I had a better answer than that. But
I think that's a great answer. And right now during COVID, with so much patient demand, a lot of the specialties probably don't have that time to recharge their batteries. And I think that's probably contributing to a lot of the burnout that's being reported, and that I'm personally hearing from a lot of our clinical staff. And I actually, so at Avenue, I get an email or two every once in a while from a primary care physician that's looking to, they're a little burnt out on the EMR. They want to do something different, and I see a lot of them trying to get into like health tech and virtual care, where they can actually feel like they're trying to do something innovative to fix the system and to get out of sort of that wheel and a cog of being sort of at the bottom of a totem pole of a larger health system. And so that's something I've seen a little bit.
Well, and to a certain extent, listen, there are absolutely situations where the physician could make the choice to not work, and they don't make that choice because they're getting paid hourly. Okay, so a lot of these doctors are getting paid $150, $200, $250 an hour. And it's because of what Dr. Falsel, Dr. Fernandez, all the people, Dr. McCarter at ChenMed have talked about. It's because they're in a fee-for-service environment that the money is just too good to pass up. And these people are working 30-hour shifts, not because they have to, but because they literally say to me, the money's so good, I can't pass it up.
Right.
So I'm not a fan of bashing physicians, but I also am not a fan of taking away personal agency and our own personal ability to make choices. And so there are absolutely physicians out there who are making the choice to burn themselves out for the sake of making more money, because physicians, myself included, are notoriously bad with money. It's like required. In order to be a physician, you have to be bad with money.
That and the handwriting.
They're trying to work their way out of their poor financial choices. So, so again, I think there is a degree of personal agency that I think can be used to address this as well.
Right. Yeah, I think that time off thing is really important. And Dr. Fernandez, I'm curious, let's take a step back from healthcare. I think we've talked about a lot of the issues here. What are you personally potentially doing to kind of work through this period of time? And have you done anything differently to just take care of yourself?
Yes, absolutely. And most of us are workaholics by nature. We love to give back and we love to work. So we have to be reminded sometimes that we need our wellness days, that we need time off. Here at ChenMed, we actually have, in addition to our time off on our vacation, we actually have wellness days. I'm guilty of having to have been reminded by my coworkers and my loved ones that I needed to take time off. I actually came from 3 days of doing so, and that was great. I came back refreshed and still wanting to get back to work, but very refreshed. But something I want to take us back to March. One quote that has stuck with me throughout this pandemic, and I hope it helps in the burnout question, is the quote that says, "Be like water." My husband loves Bruce Lee. He loves that quote. And if something I've learned from COVID, and we are learning together, my team is, we have to be like water. There are days that are very challenging. And most of our challenges, like Dr. Faisel and Dr. Bricker were saying, actually come from a lot of times even the social determinants of health. We here at ChenMed work to overcome those, but we cannot sometimes overcome everything, like transportation, if my patient's the caregiver, things like that. So not being able to provide care because of overcoming social determinants of health, that creates burnout. Like you said, we need more clinical teams, not just doctors, but nurses, medical assistants. We need a little bit more of everyone. Refreshing and restarting is important. Recognizing that you need to take the time off. Like I said, I actually needed to be reminded that I needed that, and I took the feedback. Being vulnerable and understanding that we need to take a break. And I want to go back to the question that the viewer asked earlier: how do we spread logical fear? Spreading good things is greatly done with positive reinforcement, and I can tell you I've done so throughout this pandemic by sharing trust. I don't have all the answers, just like my patients don't about coronavirus. I have questions, but I tell them the news are saying A, B, and C. We don't have to listen to everything the news says. Some of it is true, some of it is not. But I can tell you my one-to-one interactions with patients, these are the very serious lessons and consequences of this virus. You trust me with your health for everything else. Trust me in this journey. Follow the guidelines of social distancing, hand washing. And that's the only way I've been able to spread, we don't like to say spread logical fear, but since you use those words, I like to say spread logical caution, spread logical care, and instead of spread, prevent. I like to change that spread logical fear to prevent serious illnesses and diseases. So thank you, Rob.
So
Well, that's great.
We have a question from Nikhil that enters into this, and he's talking about regarding healthcare providers' burnout. To what degree is second victim syndrome a factor in causing burnout, especially during the pandemic? And I know in one of the waves, I was talking to one of the doctors in Florida, and they had said that, and one of the ChenMed doctors, one of their patients had been sent out of the hospital and said, you know, we really should keep you, but we don't have a bed for you. We don't, and therefore we've got to let you go home. You should be in the hospital. Go call your primary care doctor. So now we're laying that sort of on the primary care doctor's feet. And if something bad happens, you know, we all feel bad for the patient, but what about the doctor that was involved with that, with what's happening? And I wonder, you know, what Eric, Faisel, Aymara, what your thoughts are about that.
So I actually had a patient during the pandemic who went to the emergency room, advised by me to go, but this was at a point in time where the ERs were full and the patient was going to be sent out 2 hours away. And the patient was decided to go home. The doctor said either you could wait here and you'll be transferred to another ER 2 hours away because we don't have beds, or you can go home and watch yourself for symptoms. So thankfully, the patient had my cell phone. I talked to him maybe 5-6 times during that time period, and I was really concerned about my patient. I actually asked him to go back to the ER about 8 hours later. And this is not a blame. We're in a system together. We were getting ready for that. If this happened to more patients, what could we do as an outpatient community of doctors to relieve the emergency department? So yes, looking for burnout, for signs of burnout is important. But here at ChenMed, we were more concentrated in transforming into what we call a hero mode. What can we do more of to reach these patients? What if this catastrophe does come about? So I did witness something like that. I got my patient safely back into a hospital, continued communicating with the doctors. The patient did well. He did need to be there in the hospital, stayed a few days safely, getting treatment that I could not unfortunately give and still cannot currently give in my clinic. But I think if we keep in mind we're in this together again as doctors. We're not here to blame doctor from A place versus doctor from B place. No, we're in this together, and we're all trying to do more because that's what we signed up to do when we were doctors. At least I never thought I would have to. At the beginning, we were talking about this as if we were going into a battlefield, and we're back. And that's not the attitude we want. We want to be healers. We want to go into this. But what we do, most of us have in common, is we cannot fulfill that need to heal, to get to others. So that's what we did here. We tried to turn into a hero mode rather than in a burnout mode, and it worked for us. But I could see how it could be a problem.
Yeah, and I admit I had to look up what. That's why I turned my camera off for a second. I had to look up what second victim syndrome is. So it's when a healthcare professional makes a mistake, and then they themselves feel the shame or the guilt or sort of the mental trauma from making that mistake. So that's good. I learned something. I didn't know that I've certainly felt that before, but I didn't know it had a name. Now, I would say that I was taught in medical school and residency that I had to be perfect. I'll be honest with you. I was pretty much told that, and that imperfection was not allowed and was not acceptable. And I was thoroughly reprimanded almost any and every time there was an error. And so again, I think we're kind of paying the piper now, because I went to medical school 2000 to 2004. Okay, so not that long ago, and this was the approach that was used with me. So has medical training changed that they don't do that anymore? I don't know, but I'm sort of a mid-career physician, and that was very much instilled in me. And I'll never forget I'll just tell you a quick story. When I was in residency, I did a rotation on the neurology floor, and they were using high-dose Cytoxan for something called CIDP, chronic inflammatory demyelinating myoparesis. So it's essentially sort of long-term Guillain-Barré, and it's an autoimmune disease. And so they thought, okay, if they blast the immune system with the high-dose Cytoxan, that you'd be able to treat that. So it has to be dosed in body surface area. And I calculated the body surface area incorrectly, sent it down to the pharmacy. And guess what else do you use high-dose Cytoxan for? You use it to obliterate bone marrow in preparation for a bone marrow transplant. So I had written a dose for a myeloablative dose of Cytoxan. So it literally would have destroyed this woman's bone marrow had it actually been administered. And of course, the pharmacist caught it. And I'm telling you this story, 15 years later, because I remember it like it was yesterday. And I was a resident. My attending signed off on that, and my attending got in deep trouble. Okay, so it is. I have no answer for the own personal guilt and shame and how to best address that as an individual. But I will tell you that systematically, it depends upon your institution or whatever, but there are absolutely systems of accountability that have potentially career-ending ramifications for physicians if they make mistakes. And so is that a dynamic that needs to be changed over time? How to change it, etc. But I mean, it is all I can say is that it absolutely does add stress to the burnout that physicians are already feeling.
Yeah, and Eric, thank you for sharing that. One of the things we found in our research on ICU nurses recently was that that second victim syndrome is is particularly active during, I had to look it up as well, during COVID-19 because, at least earlier on, we didn't really know how to manage the condition very well. It was new, there weren't a lot of like treatment protocols that were in place, and so that, I think a lot of the nurses were feeling a little bit helpless as well, and certainly there were some mistakes that had been made from all the healthcare providers that were involved because, or perceived mistakes at least, because there was a new condition. So I do think that is something that's been very active during this time. And then anytime you have increased patient volume, you have a ton of stuff going on, you're seeing larger number of patients per provider, the potential for mistakes certainly goes up. And I think it was around 2000 when the To Err is Human report came out. There was a desire to shift the culture in healthcare and medicine away from this like you can never fail, you have to be perfect, to look, we need to recognize that people make mistakes, and what's important is that it's reported, the systems can be changed so that we can catch things in the future, and that we can catch it immediately if something does come up, if somebody does make a mistake, so it's not swept under the rug. And that was the result of sort of some of that work. We did a topic of medical error last week. I don't know if we mentioned that report, but that was a big one that came out in the earlier 2000s. So I do think that is something that's going on right now, and certainly contributes to stress and burnout. And it is important to recognize that there's a lot of patients flowing through ICUs and through the hospitals in certain areas, and mistakes can occur. And so systems are important to prevent those. Faisel,
well, the system encourages them. Our system, okay, it doesn't encourage malpractice. I'm not saying that it encourages malpractice. But the fee-for-service system encourages inefficient care. With any of the reasons that anyone gives why the EHR, these medical records don't talk with each other, why there's so much duplication of services and tests and all of this, is because the system encourages inefficient care. That's why pre-COVID, half of all medical care was delivered in the emergency room setting at the emergency room rates, because the system does not incentivize prevention and early intervention. And when we're talking about early intervention, we're talking about delivering efficient care. And I think that that's also one of the big drivers of burnout, because none of us went to medical school. We all have something in our, like a statement somewhere saying that I'm becoming a doctor, I want to become a doctor to help people. And you go through all these years of medical school and training, and then you get out into this world that is so disconnected. And the doctors are spending more time with the medical complexity of their documentation to get a certain level of reimbursement than they are with the medical complexity of the patient that's sitting right in front of them. And so it's not just the pathophysiology. I think that what this has shown us is that all the inefficient care that was there from before, like if let's say the inefficient care is the congestive heart failure or the COPD, like it's just exacerbated. Like this whole world that we're living in has exacerbated inefficient care. And
right.
there are only so many hospital beds. We have 330 million people. It's about like 1 million hospital beds, something like 900,000 hospital beds, and 1/10 of them ICU. We have like 100,000 ICU beds, and at least earlier, like at least a few months ago, somewhere like 60, 70,000 ventilators. So we only have a finite amount. Yeah, you can create more ventilators. It takes 6 months or 6 years to get an ICU nurse. But we only have 200,000 primary care doctors, people. There's only a couple 100,000 doctors. When you think about like all the doctors in the country, about a million physicians, but only 200,000 primary care doctors.
Mm-hmm. Yeah, and obviously primary care is something that needs to be reinvested in moving forward, particularly with the results of COVID and the potential long-term ramifications. It's going to be important to make sure patients have equitable and effective access to primary care services that can sort of prevent a lot of these high-cost episodes or patients who've developed or exacerbated existing conditions from ending up in a bad situation. So I think obviously primary care is essential. Let's all kind of start to wrap up here and end with kind of this last question. What do you think is going to be the, let's say, number one sort of takeaway from this COVID situation? We are in this together. We will make it through this. we are going to kind of band together and continue to work through the winter. What is something that's going to be a lasting impact from this in healthcare that you think? And then we'll wrap up. So, Dr. Fernandez, why don't you go first?
So I'm going to leave you with 2 words. Let's be passionate preventers. Let's each be a pioneer in that, and we'll get very far.
Thank you. Dr. Berger.
I would, listen, I can't say anything that would be better than what Dr. Fernandez just said. It's an ounce of prevention is worth a pound of cure. So let's be passionate preventers. I agree.
Excellent. And fast. Thanks, Sal.
Well, I don't think that we need to make it any more complicated than what it is. Let's not make social distancing and wearing masks as difficult of a thing to do. I mean, it's just like seatbelts and airbags, people. I mean, social distancing and masks is the same. And anyone who is trying to politicize or to downplay the long-term impacts of depression, anxiety, the impact that can happen to people's jobs and their earning ability. I mean, I think that we need to talk more about the impacts of having COVID. I'm worried about what's going to happen. Right now, we're living in a world where pre-existing conditions is something that none of us think about. But if we go back into that world again, and there's a possibility that may happen, we have now almost 10 million people who survived COVID. What would happen if the long-term effects of COVID are now excluded because of changes with how we view pre-existing conditions? There's a lot more to preventing COVID than preventing death.
Right. And I think the takeaway here that I'll leave everybody with, if you're going to take anything away from this episode, it's that COVID-19 has a tremendous impact on healthcare services and on patients across the country. It's impacted all facets of life, and particularly for health outcomes, we're going to see continued ramifications over the next several years and potentially decades. And it's going to be important that we refocus our efforts in healthcare and health policy, and as individual providers of care, on ensuring prevention and primary care is emphasized moving forward.
Dr. Dan, do you have any closing thoughts before we wrap this up?
No, I think we've talked a lot about the negative side. I think people are going to have access to direct to the doctor telemedicine like they've never had before. I don't think that genie's going back in the bottle. I think that's going to be a good thing, and I think we need to take the things we've learned from this and what we can do better. And again, I agree with Dr. Fernandez, be a passionate preventer, how we prevent more illness, and how we figure out a way to pay people for preventing illness rather than only paying them when somebody gets sick. That's what we're going to need as well. So great discussion today.
Well, to anyone who joined us online, thank you so much for joining us. For more information about today's topic and to explore job opportunities with ChenMed, please visit ChenMed.com. We believe access to healthcare is a right, not a privilege.